Welcome to the deep dive. Ever thought about those conditions that can just be ticking away inside you for years, maybe decades, without you having a clue?
Well, today we're diving into your sources on something called Autosomal Dominant Polycystic Kidney Disease, ADPKD for short. It's one of those conditions many people don't find out about until later in life, and it's got some surprising twists, our mission. You might fast track to being really well informed about ADPKD. We'll look at what it is, how you get it, the symptoms, which can be super subtle, and what it all means. Expect a few aha moments, hopefully. So let's get started. ADPKD. It sounds complicated. What's actually going on in the body at its core?
Right. So basically, ADPKD is something you inherit. It means these little fluid-filled sacs, we call them cysts, start forming in the kidneys. Think of them like tiny water balloons slowly filling up inside the kidney. Now, you're born with the genetic tendency, but you wouldn't necessarily know it. The problems usually only start when those cysts get big enough to, really affect how the kidneys work. So it's there from day one, but it could be a really long time. Decades even before you actually feel anything or know something's wrong.
Exactly, yeah. For most people, symptoms don't really kick in until they're maybe 30, 40 years old, sometimes earlier, sometimes later, it varies. And as these cysts grow, the kidneys themselves can get huge. I mean, much, much larger than healthy kidneys, especially as people get older. They can really swell up.
Wow, that's quite something. Okay, so what makes these cysts form? It's all down to genetics, right? The sources really hammered that home. What's going wrong at that basic gene level?
That's spot on. It's a fault in the genes. Basically, there's a problem in the instructions for how kidney cells should develop. So instead of making normal kidney tissue, the cells start forming these cysts. There are two main genes involved here. PKD1 that accounts for maybe 78% of cases, the majority. And then there's PKD2, which is about 15%. Both cause similar issues, but PKD1 tends to be, well, a bit more severe generally.
Okay, PKD1 and PKD2. And the inheritance, I saw that note about a 1 in 2 chance. How does that actually work? How does it get passed down?
Yeah, that 1 in 2 or 50% chance is crucial. It's because ADPKD is autosomal dominant. That just means you only need to get one faulty copy of the gene, either PKD1 or PKD2, from just one parent.
Ah, just one.
Right. So if, say, your dad has it, you've got a 50-50 shot with each pregnancy. And it's worth just quickly mentioning, this is different from a much rarer type called ARPKD that's recessive. For that one, you need faulty genes from both parents, and it usually shows up much, much earlier in childhood.
Okay, that makes sense. But what really stood out to me was that not everyone with ADPKD actually knows of anyone else in their family having it. That seems a bit strange if it's inherited.
Yeah, that's a really interesting and important point. You'd think everyone would have a family history, but in maybe up to a quarter of cases, like 1 in 4 people, they develop ADPKD without knowing anyone in the family who had it.
Huh. Why is that?
Well, it could be that a relative did have it but was never diagnosed. Maybe they passed away from something else before kidney problems became obvious. Or, and this is quite fascinating, in about 1 in 10 cases, the gene fault just happened spontaneously. It's a new mutation in that person for the first time.
Wow, really?
Yeah. We don't know exactly why these spontaneous mutations happen, but once they occur, that person can then pass the condition on to their own children in that same 50-50 way. So, it really broadens who might potentially have this condition.
Right, it's not just about looking at your direct parent sometimes. Okay, so this condition is progressing silently for years. What should people actually be looking out for? What are the symptoms when they do start appearing?
Well, as the cysts grow, they can cause a range of problems. Often the very first thing people notice is pain. Could be in the tummy, the side, or the lower back. It can be quite sharp, but usually doesn't last too long. It might be from a cyst suddenly getting bigger, or maybe bleeding into a cyst, or even a kidney stone or an infection kicking off.
Okay, pain. What else?
Another common early sign is seeing blood in your urine. The medical term is hematuria. Understandably, that can be pretty scary to see.
Yeah, I bet.
But it often clears up on its own within a week or so. Still, you should always get it checked by a GP just to rule out other causes.
Definitely. Now, those sound noticeable, but you mentioned something before. The sources suggested that maybe the very first thing happening biologically, even before pain or blood, is high blood pressure.
Yes, exactly. And this is so important. A lot of experts consider high blood pressure hypertension to be the actual first effect of ADPKD kicking in. But the tricky part is, high blood pressure usually has no symptoms at all.
Like the silent killer thing.
Precisely. So it often only gets picked up during a routine checkup, maybe at the GP, for something else entirely. You'd only likely get symptoms like bad headaches, blurred vision, nosebleeds, maybe shortness of breath if your blood pressure gets really high. And catching it early is vital because untreated high blood pressure is a huge risk for heart attacks, strokes, and kind of ironically, it makes the kidney damage worse too. So yeah, blood pressure monitoring is key.
Okay, so beyond pain and the hidden threat of high blood pressure, what else can crop up as things progress?
Well, people with ADPKD are definitely more likely to get kidney stones. They can cause, really intense pain, often radiating down the back or side. Yeah. And urinary tract infections, UTIs, are nothing to watch. Now, ADPKD doesn't make you more prone to simple bladder infections, the lower UTIs. But if you do get a bladder infection, there's a higher risk it could travel up into the kidneys. And an infection in the kidneys, an upper UTI, is much more serious. You might get a high fever, shivers, feel really sick.
So you need to get onto those quickly.
Absolutely. If you have ADPKD and think you have a UTI, you need to see a doctor pretty sharpish.
Got it. So all these issues, they point towards the kidneys not working as well over time. How does that decline usually happen? And what are the signs when things get really advanced?
Yeah, unfortunately, most people with ADPKD will see their kidney function go down over time. This leads to what's called chronic kidney disease, or CKD. The thing about CKD is, like high blood pressure, it often doesn't cause symptoms until it's quite advanced. Usually not until stage 4 CKD, which means you've already lost about 75% of your kidney function.
Wow, 3/4 gone before you feel it.
Often, yes. And the final stage, stage 5, is kidney failure, or end-stage renal disease. That's when you need treatment like dialysis to stay alive. Symptoms of kidney failure itself can be quite varied. Things like losing your appetite, losing weight without trying, getting swollen ankles, feet, or hands. That's called edema. Also shortness of breath, needing to pee more often, especially at night, itchy skin, feeling nauseous, and for men, erectile dysfunction, or for women, periods might stop. So you can see why catching things earlier, especially that high blood pressure, is just so crucial for trying to slow things down.
Absolutely. So given that symptoms can be vague or appear late, how do doctors actually diagnose ADPKD? What's the process?
Diagnosis usually happens in adulthood, typically over 30. A GP will ask about your symptoms, of course, and crucially, about your family history. Sometimes they can actually feel that the kidneys are enlarged just by examining your abdomen. Then they'll order tests, definitely blood pressure checks, urine tests looking for any blood or protein. And blood tests to work out your GFR, that's the glomerular filtration rate, basically a measure of how well your kidneys are filtering blood. Over 90 is considered healthy.
Okay.
And scans are really important, usually an ultrasound first to look for the cysts in the kidneys and often the liver too. Sometimes a CT or an MRI scan gives a more detailed picture. An MRI is particularly recommended if there's a family history of brain aneurysms, which we should probably talk about later.
Right, okay, so scans are key. This brings up a really big question, though, especially for people who know ADPKD runs in their family. Is it always best to get screened to find out if you have it, even if you feel fine?
Yes. This is, well, it's a bit controversial, actually. There are strong arguments on both sides. Some doctors argue against routine screening, historically because there wasn't a treatment to actually stop the cysts growing anyway.
So finding out just causes anxiety.
Exactly. It could cause a lot of stress, worry about the future, insurance issues, you name it. Plus, scans, especially in younger people, might miss very small cysts, giving sort of false reassurance.
Okay, that makes sense. But what's the argument for screening then?
Well, the thinking has shifted a bit. Even if you can't cure it, finding out early means you can manage things proactively, like getting high blood pressure under control early, which we know reduces the risk of heart problems and stroke. Also, knowing you have it means potential complications won't be such a shock, and they can be treated quickly if they arise. And, crucially, there is now a treatment called tolvaptan, which can actually slow down the cyst growth for some people.
Ah, right. That changes things.
It does. So the decision to screen, it's really a personal one. It needs a proper chat with your doctor, maybe your family, weighing up those pros and cons for your own situation.
Yeah, sounds like a deeply personal calculation. But okay, let's say someone is diagnosed. No cure yet, but it sounds like there's a lot that can be done to manage everything.
Oh, absolutely. There's a very clear management path. You'd usually be referred to a kidney specialist, a nephrologist who'll work out a plan with you. For high blood pressure, it's usually medication. Things like ACE inhibitors or ARBs are very common. They help relax blood vessels and protect the kidneys. And lifestyle stuff is huge too, especially cutting way back on salt, like less than 6 grams a day.
Right, what about the pain?
Pain often gets better if you treat the cause, like an infection or a stone. For general pain relief, paracetamol is the first thing to try. If that's not enough, stronger painkillers like tramadol or maybe oxycodone might be prescribed. One important note is to generally avoid NSAIDs, that's things like ibuprofen or naproxen. They can potentially harm the kidneys and mess with blood pressure meds. Short courses might be okay sometimes, but only under medical advice.
Okay, good to know.
Sometimes, if a particularly large cyst is causing a lot of pain, it can actually be drained with a needle to relieve the pressure.
And kidney stones and UTIs?
Kidney stones often pass if you drink lots of water and take painkillers. Bigger ones might need treatment to break them up, like using sound waves, that's ESWL, or a tiny telescope procedure. UTIs need antibiotics quickly, plus fluids and paracetamol. As we said, getting treatment fast is key, especially to stop infection spreading into the cysts, which makes it much harder to treat. Very rarely, if infections are severe and keep coming back, removing the affected kidney might be considered.
And you mentioned that newer drug, tolvaptan.
Yes, tolvaptan. It's a big step forward. It's specifically for adults who have CKD stages 2 or 3, and clear signs their disease is progressing quickly. It works by slowing down how fast the cysts grow and how much the kidneys enlarge, hopefully keeping kidney function better for longer. It does have side effects, though, commonly making you very thirsty and needing to pee a lot. And it needs regular blood tests to monitor your liver function, as it can potentially cause liver problems in some people.
Okay, so close monitoring needed there. Anything else in terms of management?
Just one more thing, avoiding injury. Kidneys with lots of cysts are more fragile. So contact sports with a high risk of impact, like rugby or boxing, maybe even football, are usually best avoided to prevent a cyst rupturing or bleeding.
Right, makes sense. Okay, that covers managing the condition day to day. But what happens if, despite all that, kidney function really declines significantly? What are the options then?
When it reaches kidney failure, or end-stage renal disease, there are essentially two main treatment routes to replace kidney function. One is dialysis. That's using a machine to filter your blood, doing the job the kidneys can no longer do. There are different types of dialysis. The other main option is a kidney transplant. That's surgery to give you a healthy kidney from a donor, who could be someone who has passed away, or increasingly, a living donor.
A living donor.
Yes, you only need one healthy kidney to live a normal life. Often a close relative is a good match, genetically speaking, but living non-related donors are possible too. A transplant is often seen as the best long-term solution if possible. It's also important to mention that for some people, maybe those who are older or have lots of other serious health issues, they might choose not to have dialysis or a transplant. Instead, they opt for supportive care, focusing on managing symptoms and maximizing quality of life.
So there are options, but they're major interventions.
They are. But, the fact that we have these options, alongside all the ways to manage symptoms and slow progression earlier on, it's a very different outlook compared to decades ago.
Definitely. Now, something that really jumped out from the sources was that ADPKD isn't always just confined to the kidneys. It can pop up elsewhere in the body, too. That was a bit of a surprise.
It was, yeah. It's a systemic condition, meaning it can affect multiple body systems. Cysts developing in other organs is quite common, actually. The liver is the most frequent place to see cysts, outside of the kidneys.
Liver cysts, do they cause problems?
Usually they don't actually affect how the liver works, which is good, but they can sometimes get infected or cause tummy pain, maybe some swelling or bloating if they get very large. Very rarely they might cause jaundice, which is yellowing of the skin and eyes. And in really, really severe cases, surgery on the liver or even a liver transplant might be needed, but that's uncommon.
Okay. What else beyond the liver?
Well, because of the link with high blood pressure, people with ADPKD have a higher risk of cardiovascular disease, CVD.
Oh!
That includes things like coronary heart disease, where the arteries supplying the heart get narrowed, increasing the risk of heart attack and also stroke. So again, managing blood pressure meticulously is vital, as are all those healthy lifestyle things. Stopping smoking, sensible alcohol limits, exercise, healthy diet. They're not just nice to haves, they're really crucial.
Right. And then there was the one that sounded, frankly, quite scary, brain aneurysms.
Yes, that's probably the most serious potential complication outside the kidneys. Brain aneurysms are definitely more common in people with ADPKD than in the general population. Estimates vary, but maybe around 1 in 10 people with ADPKD develop one.
And what exactly is an aneurysm?
It's like a little bulge or weak spot in the wall of a blood vessel in the brain. High blood pressure can make these weak spots more likely to bulge. Usually, an aneurysm doesn't cause any symptoms itself, just sitting there silently. The danger comes if it ruptures or bursts. If that happens, it causes bleeding to the space around the brain, which is called a subarachnoid hemorrhage.
Subarachnoid hemorrhage, that sounds incredibly serious. What would be the warning signs?
It is a medical emergency Absolutely critical to get help immediately. The classic sign of a rupture is a sudden, incredibly severe headache. People often describe it as like being hit over the head, a thunderclap headache, the worst pain they've ever known.
Wow.
Other symptoms can include a very stiff neck, feeling or being sick, finding light unbearable, blurred vision, sudden confusion, maybe stroke-like symptoms like weakness down one side, or even losing consciousness. It needs immediate 999 or emergency services.
Okay, that is terrifying. So is there screening for these aneurysms in people with ADPKD? Can they be found before they rupture?
Thankfully, yes, there is screening. If you have ADPKD and a family history of brain hemorrhages or aneurysms, you'll typically be offered screening. This is usually done with an MRA scan magnetic resonance angiography, which is a type of MRI that looks specifically at blood vessels. If they don't find any aneurysms, or only very tiny ones, they'll usually recommend repeat scans every few years, maybe every 1 to 5 years. If they do find an aneurysm that's large enough to be a concern, doctors will discuss treatment options to prevent it from rupturing. This might involve surgery or a less invasive procedure to clip or coil the aneurysm. So yeah, understanding these wider risks beyond just the kidneys is really key for managing ADPKD properly, making sure nothing takes you completely by surprise.
Absolutely. Well, we have certainly taken a deep dive into autosomal dominant polycystic kidney disease today. We've gone from the genetics right through to the wide-ranging effects on the body and some of those surprising ways it shows up.
Yeah, we've seen how it's inherited, but often stays hidden for so long, and how crucial managing blood pressure is from the get-go. Plus, yeah, the importance of being aware of those potential issues outside the kidneys, like the liver cysts and especially the aneurysms. It really requires a whole-body perspective.
You've shared so much valuable stuff today. It really helped connect those dots for us on what sounds like a really complex condition. Thank you. And for you, our listener, maybe a final thought to take away and mull over. Thinking about how much ADPKD can vary from person to person and how treatments and our understanding are always evolving. How might knowing more about your own specific genetic makeup or your detailed family health history really shape the proactive choices you make about your health in the future? Something to think about. Thanks so much for joining us for this deep dive. We really hope you feel that bit more well-informed.
For more detailed explanations and related topics, we invite you to watch our videos on our YouTube channel. Don't forget to like, comment, and subscribe to stay updated with our latest educational content. Thank you.